Pain, that medically elusive evil. What about changing the focus from controlling pain to understanding pain as more than a symptom? Can pain be cheated? My name is Dr. Dean, chiropractor and physiotherapist. My goal is to reframe how medicine understands pain to improve care. This podcast series is dedicated to a same-day conservative treatment for low back pain. This podcast has a companion published article, number 12. Welcome to the Pain is Not the Only Problem podcast. The essentiality of conservative care is being reevaluated. The contributors to patient symptoms are being re-explored. All options are on the table. Article 12. Pain is not the only problem. Dysafferentation. These articles intend to reevaluate the prevailing clinical practices thought to manage low back pain, submit and debate novel low back pain contributors and mechanisms, meet patient expectations and satisfaction and clinically meaningful results, recommend a conservative non-surgical course of care to override pain instantly, and restore ADLs and patient confidence on the first visit at low cost. Dysafferentation is the prolonged bombardment of afferent signals to the dorsal root ganglion, resulting in habituation of central sensitization and peripheralization of symptoms to muscles and joints. In other words, prolonged local and systemic inflammation, understood to be unresolved healing process related to low back pain, can lead to symptomatic response or symptomatic centralization, causing irritation or degradation of the nerve sheath. Changes in the nerve sheath cause an infiltration of nerves into adjacent tissues known as wide dynamic range cells that can interpret any signal, joint position, muscle tone, or load, as pain. Increase in acetylcholine causes the muscles to increase static tone. The low back muscles become chronically contracted and can produce trigger points. Trigger points are oxygen-starved tissue due to chronic tone. Imagine wringing out a wet rag. The same occurs with trigger points. The rag is an overly tensioned muscle, and all of the blood is squeezed out, and therefore oxygen is removed from the muscle. This tensioned muscle feature dominates the life of the low back pain patient. Chronic history of brief, sudden, shock-like episodes of radical lockup of the spinal muscles, either seconds to minutes, sometimes requiring an emergency hospitalization. This feature occurs with dysafferentation and presents as a co-contraction of the spinal agonist and antagonist, including the deeper column muscles, as well as the multifidi, rotatories, and intertransversii. This co-contraction event is called sympathetic atonia. The result of dysafferentation is altered reflex arc. The proprioceptive afferent pathway, post-lateral spinothalamic tract, that normally sends signals the muscle tone and joint position, which is hijacked by the nociceptive signaling, and joint position muscle contraction sense signals interpretations are converted into the pain pathway signal to the cortex. Movement becomes painful for no reason other than dysafferentation, not a bulging disc, not spinal cord compression, not by loss in disc height, and not by the formation of osteogenic remodeling, by something you can't see on plain film or advanced imaging. Note that dysafferentation occurs among the muscles innervated by the dorsal horn nerve roots and includes only those signals, none from the disc. The main features of dysafferentation are 1. Unresolved inflammatory process. I put the quotes around process because the process has failed so many times, it is now impossible to restore tissues to their healthy state, although there is an attempt to do so. 2nd, altered arc reflex. And 3rd, peripheral modulation, damaged muscles that do not heal. These 3 features describe almost every low back pain patient that I have seen. Contributors to dysafferentation include sympathetic amplification, neuroendocrine mechanisms that influence psychosocial stress on the sympathetic nerve system. Contributors to dysafferentation include sympathetic amplification, neuroendocrine mechanisms that influence psychosocial stresses on the sympathetic nervous system, chemical links between emotions and the immune system, the HPA axis. Increased experiential stress produces glucocorticoids, natural anti-inflammatory mediators, and dysregulation of cortisol serotonin, leading back to stress and the inability to adapt, chemically speaking. Dysafferentation is a chemical process and cannot be seen on plain film or in advanced imaging. There is no blood test for dysafferentation. Examples of the patient experience related to unresolved low back pain and dysafferentation include anger and irritability that increases blood pressure and resting heart rate, anxiety and panic that creates headache, nervous habits, changes in eating habits, and shingles, depression, which leads to sleep disturbance, decreased libido, exhaustion, and disinterest. Clinical observations related to unresolved low back pain: body tension, spasm, and trigger points, sympathetic atonia, heightened sense of survival, emergency state decisions, overreacting and brashness, coping delays and sacrifices, approval seeking while attempting to demonstrate command, delayed healing, symptom magnification, inability to reset, organic changes, cortisone overproduction, GI inflammation, altered gene expression. Causes for sympathetic amplification related to dysafferentation: death, divorce, unexpected changes in relationship, family drama and abuse, job loss, job dissatisfaction, the recognition one gets at their job, financial survival or decay, solvency, insolvency, and lateness, chronic illness in self or others, depression, easy to anger, poor self-esteem, catastrophizing, appearances in class lifestyle, keeping up with the Joneses, dehumanization, discrimination, feeling trapped, feeling invisible, all related to low back pain. This article expresses the importance of recognizing that pain is not the only problem. Unresolved low back pain can be caused by prolonged bombardment to the sense signal nervous system and amplified by inflammation and life situation that stirs the sympathetic pathway. Advocate for your patients by taking a good look at a complaint of ongoing low back pain tension combined with an amplified sympathetic lifestyle. Thank you for joining me today. Let's advocate for improved patient satisfaction and for the profession. Let's demonstrate a cross-cultural willingness to strengthen medicine. Thank you.